evening. My name is Brian Gray. I practice in Washington, D.C., and have been a user of accelerated orthodontic techniques for a number of years. I think that the stuff on the slide is nice, but probably the most important thing is what I'm bringing up right now, and that's that I practice full-time. I teach usually on Fridays, and otherwise I'm in the office Monday through Thursday. I think it's probably also important that I share with you that I'm not employed by any company, including the one I'm speaking for tonight. I don't own any stock, securities, or interest in any dental company, and no one in my family does. But I do a lot of consulting that I find very enjoyable. It's a chance for us to evaluate and look at different products, do research, and these are some of the companies that I'm working with presently or have recently in the past. Generally just products related to dentistry that are new and have already gone through FDA approval, and we help them develop the product so that it's more capable of use in a clinician's hands. I don't accept any free product either. We'll either use a product and return it, or it's one use only, or we'll pay for it ourselves, just again to be able to remain above board. The disclaimer for tonight is real simple. I'm not compensated for any consulting with Propel or for evaluating the products, but I do get paid to teach and share this slide with you because of that. The information that I'm going to cover tonight, I put mostly in an article that was published in the Dentistry Today magazine journal about 2 years ago. And it has, I think, about 63 references. So pretty much anything that we talk about, you can go to the article and you can find reference material that's associated with it. Also, this is part 2 of a lecture series. If you watch the first one, it goes into the science in greater detail and also shows the start of some of these cases that I'm going to show in more detail tonight as well. So with the advent of clear aligner therapy, GPs were finally able to really start doing ortho in their practices, and I think it was a game changer, a real shift in dentistry, starting around the new millennium, around 2000. Invisalign was the first into the market. Interestingly, a lot of their patents expire this next year, but I also feel that they're so far ahead of the game with other competitors that it'll be years before I think they catch up. The science and research that they're putting into the development of their aligners is incredible, and I like to say when I'm speaking for them that the lecture I'm giving will be probably outdated about 6 months down the road because it's changing so fast and there's so many neat new things. But some of the things that have remained true is the ability to do some of the more advanced techniques, including sagittal shifts and more difficult movements. Probably the biggest thing was the yearning to have shorter treatment times. And it wasn't until accelerated ortho came along that we were able to accomplish that with success, reliability, and confidence. There's a number of different techniques that you can use to accelerate the movement of teeth. We're going to just cover 2 of them tonight. Again, all these are covered in the first lecture if you'd like to look at some of them in more detail. But tonight we're going to talk mostly about cyclical forces or vibratory forces and manual osteo-perforation, sometimes called micro-osteo-perforation. We'll cover the manual osteo-perforation first, but before we do, I want to just cover a little bit of basic technique related to tooth movement. When we place force on a tooth, the tooth moves through bone, and the way that it moves through bone is that you have cells that break down one side and build up on the other. We're all familiar with osteoclasts and osteoblasts and how they work. But that's tied into Burstone's 3 phases of force, and I think this is an important thing to understand if you're doing orthodontic movement. When you first put pressure on a tooth to move it through bone, we undergo what's called the initial or strain phase. During that phase, no movement occurs. You're just basically putting pressure on the tooth. It's compressing the periodontal ligament, and it's putting pressure on the bone itself. Over about the next 2 to 3 weeks, you have what's called a lag or hyalinization phase. And during that phase, there's also very, very minimal tooth movement, but there's a lot of changes that are going on in the bone itself to get the tooth ready to move, which occurs in the 3rd phase, or the post-lag phase. During that period, the hyalinization layer breaks down, and it allows the tooth to move quickly via osteoclastic resorption, the use of osteoclasts to break down bone. If we were to look at a model of that, you'd look at putting force on a tooth via a bracket in this case, and that force is going to push the tooth sideways, and when it pushes sideways, those cells move into the bone, cause breakdown, and then the tooth is able to move. That's called frontal resorption. There's some other types of resorption that I referred to again in the article that covered things in a little bit more detail. But one of the things that I do want to make sure we talk about related to resorption is something not related to frontal or bone resorption, and that is EARR, or external apical root resorption. It's generally attributed to being caused by too much velocity, trying to push a tooth through bone too quickly. We don't see that with clear aligner therapy, the use of Invisalign or some of the others. And I feel that the reason is very simple, straightforward, and more of a physics issue. I don't think you could possibly use aligners to move teeth through bone quickly enough before the plastic would just deflect and the tooth wouldn't move. It's kind of a built-in safety mechanism, and I find it really valuable for safety as far as the movement of teeth with clear aligner therapy. In I think over 3 million cases now with Invisalign, we've yet to see a single recorded case of external apical root resorption. That external apical root resorption occurs particularly with brackets or fixed ortho via that same idea that we talked about. You put force on a tooth and that force goes through a bracket. But if you put too much of it, what really starts to occur is the tooth does this, it tips over. And when it tips over sideways, now the force is directed in a different direction. You actually have a force going like that, which drives that root now into the bone. At the tip is where the breakdown will occur. And when you see that breakdown, you'll see actually a resorption of the root itself, and the root becomes blunted or short. Here's just a typical Panorex showing that in the anterior region of these teeth, where you can see that area in the circle has had a breakdown of the root structure at the apex. So in essence, what we'd like to do is move teeth through bone by making the bone softer. We call that the regional acceleratory phenomenon. And the idea behind it is real simple. Let's use light mechanical forces with a constant, gentler move. And instead of trying to have the bone be hard and dense, let's try and make it soft. I like to use what I call the fence post analogy. We'll take a quick peek at that. I use this analogy oftentimes with my patients. It's a great way to share the idea with patients. I also use it when I teach at the university to discuss it with the students. So you just basically imagine a fence post, a fence in a farm, for instance, and we'll look at just one individual fence post. If we want that fence post to stay exactly where it's at, what we do is we mix up some concrete, put it in the ground around the fence post, and then after it sets, you see on the left-hand side, the fence post is not going to move. That, in essence, is what we have with teeth. They're locked into the cortical plate, and they really won't move. If you try to do it, you see what happens on the right. The fence post will bend or break above the ground. We see that occur with abfraction lesions that are, again, related to interferences, but it's the same idea. If you put heavy force on it, you'll see something occur down lower in the bone or in the ground, as we like to say. So when we use accelerated tooth movements with clear aligner therapy, basically what we're doing is making a space around the bone or around the fence post where the ground now becomes, instead of concrete, more like quicksand. And that fence post can slide easily in that quicksand to a new position, and then the quicksand turns back into concrete. It hardens up again. That, in essence, is the regional acceleratory phenomenon, so that when you put pressure on the tooth and it moves sideways, there's space for it to do it because it's mushy and it's soft, and the tooth is able to move that way. Going on and talking a little bit about micro osteo-perforation, or manual osteo-perforation, MOP as we like to call it. The idea behind it is to create small areas of inflammation in the bone to allow the teeth to move a lot easier. When we do that, we're able to switch aligners weekly or as short as every 3 or 4 days instead of 2-week intervals. We'll look at this and we'll talk about this in a little bit more detail later on. But the mechanism is really the same for any of the different corticotomy techniques, and that is we create bone injury or inflammation, and that causes a cytokine cascade to occur. That cytokine cascade speeds up the rate of bone remodeling and reduces the bone density. When the bone density is reduced, the bone becomes more like quicksand, and then the tooth is able to move. How do we create those areas of inflammation? Well, again, in the previous lecture, you can look at all the different techniques of corticotomy. We're going to, though, focus on 3 different types of Propel devices that are available. This was a single-use original device that Propel came up with, and the idea behind it is pretty simple. You use the little depth limiter to make a specific, detailed, small dimple in the bone, and it could be dialed into anywhere from 2 to 7 millimeters, and you go ahead and make that through the cortical plate, creating a small ball of inflammation. I like to think of that as being about the size of a 5 millimeter sphere. And we use this device with a little retractable sleeve so that we can screw in and screw out, creating those areas of inflammation. Propel came out with a second device, which was one with a reusable handle. The first one wasn't very eco-friendly. The second one had a lot of nice advantages as well. It's got a lot of nice heft to it. It's heavier and easier to hold in your hand, in the palm of your hand. And they had 2 different types of tips that were associated with that as well. Finally, they came out with the driver, which is what we all have been hoping for. This occurred about 2 years ago that they first started talking about it, came out with it available to the public about 1.5 years ago, I guess. And the idea behind this is that we're able to drive small holes into the bone, and now we have a lot more control over doing it. It's a lot easier. You don't have to use your wrist and your elbow as much, and it's very safe because you can dial in an exact depth. It works really, really well, and the amount of disposables are reduced to just the tip itself. So if we look at that technique, the mop technique, what we're going to do is just walk through some easy steps. We first evaluate the area, identify where both the tooth roots are and the nerves. We want to make sure that we're obviously not going to go in a nerve. If you're in the maxilla, you want to make sure you're not going near a sinus. Then what you're going to do is go ahead and wipe down the area with chlorhexidine, and then you're going to anesthetize. We'll cover the different types of anesthesia that you can use. There's many ways to be able to do that and accomplish it well, and we'll look at those in detail in a bit. When you're using the driver, and this is the single-use driver, the original one, the idea is to just take the driver out of the package, go ahead and dial in your depth, 3, 5, or 7 millimeters. You hold it directly at the gingiva at a 90-degree angle, rotating it clockwise with a light, gentle pressure. You turn this device until the light comes on. There's a little LED light that's built into it. Once the light comes on, you've reached the proper depth, and then you can just back it out. The reusable handle technique doesn't have the LED light available to it, but it does have that little tip that identifies exactly how far you're going to turn. And the tip itself, where it used to bind, will spin a little bit so that it doesn't bind with the tissue. Finally, the power driver really is basically a handle with a head, and then the components being the little drill bits themselves. This is a breakdown of the instrument. You can, again, get this information from Propel itself. It's very similar to a TAD driver. You can use light, gentle pressure because the torque on it is wonderful to be able to place the right depth that you'd like to. But the other nice thing that I really like about this is that it's easy to make sure that you've got the angle directly at 90 degrees in all the different 3 axes of movement. So it's easy for me to center it and make sure I'm going in the right direction, go slowly, and put my small dimple in the tissue and back it out easily. These are just the steps, again, that we use when we're looking at it. So if we were to just compare these different drivers that Propel has, the new one is easy to use and it's very intuitive. It only takes a second to figure out. I like the tactile sensation that's associated with it. It's lightweight and sits well in your hands so you don't get fatigue. It's very eco-friendly. You just have the little tip. It's literally the size of a burr. And I think that that's really the great features with it. With the original one, I like the tactile sensation of that generation one, and I like the LED light. It's great for small, quick cases, and the same with the newer one, the second generation one. It's nice and firm in my hand. It's a little heavier. It's got good heft, as I like to say, to it, and it's more eco-friendly than the original. So we use all three different types in our practice. Generally, if I'm doing a case at the start, I'll use the driver. I like the power driver, but I like the little ones for mid-treatment because they're quick and easy to use, and I could just dispose of them without any trouble. Looking at these perforation patterns, I want you to take a peek up there at tooth number 8 in particular. If that tooth was facial, and we'll see a case of this in the future, I would make 2 or 3 perforations on either side of that tooth to help move it lingually, especially if I'm going to accomplish root torque, where you will see in a couple of these Clinchecks power ridges that show up on the Invisalign aligner itself. Now imagine that those again are small 5mm spheres of inflammation. You can see the blue showing up where we would actually have those areas of inflammation occur. That will free up that bone and allow it to move. Now typically what I'll do is I'll put those little small spheres of inflammation on the side where I'm going to have the pressure, where I'm going to be moving the tooth. So in the case on the right, you'll see that I'm going to put 3 little perforations because I want to move that canine a little bit distally. In particular, there's some root torque associated with that, and it gives me the ability to do that by making the bone softer in that direction that I'm going to be moving it. That's one of the things that I've picked up over the years of using Propel, is that I'm much more specific about where I want to create the inflammation, because it really truly can be localized. It's a much kinder, gentler way than either piezo or the Wilco technique, which are both wonderful techniques, but much more aggressive in my mind. So where exactly do I perforate? Well, my goal is to go ahead and get it in those areas where I want to have the tooth move, and that could be either on the palate or on the facial side. I can control the depth and the setting and pretty much everything I need to. The palate used to be sometimes difficult to get to with the older instruments, and it's very easy now with the driver, the power driver itself. Whenever we do it, prior to actually seeing the patient, I'll sit down and I'll map out exactly where I want to place my small perforations on a little chart. I just use a little red or a blue marker, and I make dots so I know exactly where I'm going to be placing them. This shows the typical depth of 3 or 5mm, which is generally what I use. Rarely do I use 7 at all. It's only in the very distal, especially if I'm looking at doing molar uprighting. I might go with something deeper because the cortical bone is a lot thicker in the back there. I save these sheets so that I can be able to refer to them down the road when I'm looking at the case a little bit further on in treatment. Sorry here. This is a procedure checklist that we use. It's nice to have this in front of you each and every time. The reason that I like to have it in front of me every time is that I'm a big believer in SOP, standard operating procedures, and it's easy to forget a step. For instance, forgetting to just wipe with chlorhexidine, making sure you have something like a saliva ejector handy, etc. Just to go through the list and have those things ready, just a quick check for us to make sure that we've got everything there, and then we're able to jump into treatment itself. Prior to doing any micro or manual osteo-perforation, we're going to go ahead and use some sort of anesthetic. I've actually done some cases without any anesthetic. It's generally for the few patients that have said, yeah, let me try it without it. I wouldn't recommend it. I certainly wouldn't want it myself, and I prefer to be numb. So we like to use some of the heavier gels, as they like to say. They're called Profound. Generally, that's a kind of a moniker that's been used with these. It's very similar to EMLA, which we used in dentistry about 15, 20 years ago. Generally, it's a mix of lidocaine, tetracaine, and prilocaine, sometimes with some phenylephrine in there as well. The material itself could be available at these different pharmacies, although there's others that can do this as well. And if you have a pharmacy that does compounding, they'll go ahead and do that for you. Generally, it's dispensed in a 10 cc or 10 ml bottle or syringe, and we're going to go ahead and apply it by rubbing it on dry tissue. So we're going to first just wipe the tissue down with a little chlorhexidine. We dry it off, then we put on a thick layer of this. We generally put it on a gauze pad, which I'll show you in a moment. And we let it sit for 4 minutes, then we wipe it off, and then we let it sit another 10 minutes. And then we'll go ahead, as you see in number 6, we'll do sounding. We'll go ahead and test with the periodontal probe to see if the patient's numb. And if they aren't, I'll go ahead and reapply a little bit. If they still feel like they're not numb, we just go to infiltration. This is a typical setup that we'll use, and you can see that gel on these gauze pads that we cut into little strips. We'll go ahead and put that on it again. Afterwards, we rinse real well, and then we wait another 10 minutes for full penetration to occur, generally via the tetracaine. So there's the material itself. If we don't have good success with that, I'll go to local infiltration. I never give a block. I just generally do just infill right around the area where I'm going to be treating. The cortical bone itself doesn't have any innervation, so I'm not worried about that. It's really going to be the periosteal layer that's going to have innervation, as well as the attached and unattached gingiva. So making sure that those are amply numb is the best option, I think, for us. And then I actually prefer not to have the PDL numb, because the patient can sometimes let me know if I seem to be getting close to it. If I do use that local infiltration, I usually use septicaine or carbocaine, but keep in mind that carbocaine may not contain epinephrine, which can cause a little bit of additional bleeding. This is what the little mop sites look like after you've done them. We'll walk through some cases where you can actually look at these in a little bit better viewpoint. Post-treatment-wise, generally my patients have some tenderness around the site where we've done it, and it never lasts more than a couple days. We usually say it's similar to cranking down on a wire for traditional ortho. When patients do take a pain medication, and we typically want them to take something, we have them take Tylenol. We never have them take a non-steroidal anti-inflammatory, because that prevents exactly what we're trying to do, which is to create inflammation. The ones that you would not want to use would be any of the ibuprofens like Advil or Motrin, but aspirin would also be not recommended for use because of the same idea. It's going to act as an anti-inflammatory. Typically, perforations last anywhere from 12 to 16 weeks. I put down 10 to 12 weeks there because that's kind of the conservative number we've used for a long time. Originally, I actually felt it was only working for about 8 weeks till we really started doing our studies and looking at cases and seeing that we still were getting good release of movements long after the 8 weeks. So 12 to 16 is more likely what we'll see. Just a quick note is that occasionally we will use an opioid, and I know with all the opioid awareness these days that we're very careful about that. But if I do, I'll use Percocet. Percocet is acetaminophen, and with the hydrocodone, oxycodone, and any one of those is going to be good. I think for just a day. You can usually give them 4 pills. It's going to be more than enough, and it helps to get them through that first day without too much difficulty. These are the different types of, again, corticotomies that exist. The one on the left is what's called a Wilco technique developed by the Wilco brothers in Erie, Pennsylvania. It's an aggressive technique that generally nowadays we typically see only associated with cases that have some sort of periodontal component that is relatively severe. A less invasive method is to use piezo surgery, and with that you literally can use a piezo knife to go ahead and make your dimpling and incisions in the bone right through the tissue. It's very similar to using a Cavitron or a striker saw. It basically oscillates at a certain frequency to help create that bone destruction. Clearly, the most conservative way is to use micro osteo-perforation. Not only is it much more conservative and less invasive, but the recovery time is wonderful for it, and it's something that you don't need to have specific training for, like you do with the 2 techniques that you see on the left. The obvious benefits to it that we like to share is that it's microinvasive, as we talked about, and we can do it chairside without any time at all. I really like it for releasing difficult movements. You'll notice that in some of these cases that we look at, there are just a few teeth that have a lot of work that need to be done, and those are the ones that I'll focus in on. By doing that, it'll accelerate the treatment and increase the predictability for me, which saves a lot of time for both me and the patient. I'll share with you how that works near the end of our lecture tonight as well. The benefits to your practice are that it literally will attract new patients. When they hear that you're doing accelerated ortho from friends, they're going to come in and they're going to look for treatment. I think that it also reduces patient burnout. Of all the things that the bullet points on here, probably the nicest one is that it reduces patient burnout. If I've got a complicated case that is going to be, say, in the 40s or 50s with the aligners, you know, if it's 48 aligners, that's 2 full years of typical treatment with Invisalign before you have refinement or mid-course correction. So those cases tend to drag on, and the patient literally just, it's like running a marathon and they're on mile 24. They really just want to be done with it. So we found that it's great for reducing patient burnout on these longer cases, and where in the past we used to not talk about that with patients, we now share that with them at the very start of treatment, actually at the consult, and introduce the idea to them. And if they jump at it, we go ahead and do it right away. If not, we'll remind them a couple times throughout treatment, and oftentimes patients will come around to the idea of doing it and find out it's not nearly as drastic as they think it would be. Let's take a look at a few cases. These are cases that I showed similar in my first lecture. Leo was one of the first people that we used with Propel, and I'm just showing using it with a cotton swab here. We're going to go ahead and anesthetize him with some Septicane in this case. And then we go ahead and start right in on the micro-osteo-perforation. You get a little bit of bleeding, and I show these slides because I want to be realistic about the fact that there's a little bit of bleeding, but it's really easily addressed. If you put a little pressure on right afterwards with the wet gauze, it stops almost immediately. I'm going to show you kind of the worst case scenario there and how it looks after you've just wiped it and let it dry. Those are the perforations that we placed in his case. And sorry, I got to repeat on these slides here, so as soon as my computer speeds up, we'll jump through them. But the same idea, that's typical, the amount of bleeding that you see. It's not a big deal, it wipes off, you're all set. I want to show you something also. If you look over on the far right side of the picture, I put my arrow on it right now. That's a place where when I was doing it, I was placing a lot of force, and I actually skipped the little burr right through the papilla. You'll see that it completely heals up, but it was one of those things where, again, I was learning the technique, and I share these things with you so that you don't have to make those same types of mistakes. There he is with that little cut there. That's immediately after, before we've even actually really wiped it down. You're able to take people from a crooked position to a straight position really, really quickly, and we'll look at a couple cases with Invisalign where we went ahead and did that. Emily's a 26-year-old female in great health. She's got a class 2 half-cusp occlusion that she wants to leave because she actually wants to get pregnant, and the whole purpose behind her doing this is that she wanted to get through treatment quickly. She also was worried about these black spots on her teeth, which you'll be able to see here. Which were really just kind of cervical abfraction lesions. Now, this is the type of situation where I actually want, if I want to get that lingual movement of those front teeth, I'm going to go ahead and place perforations on both sides so that I can get that sphere of inflammation to actually go to the palatal side. In her case, I didn't do any palatal perforations. I did them all on the facial, and we were able to get good movement. You can see the Panorex down below. Here's Emily, and I'll show you her Clincheck real quick. I believe that she had, I'm trying to remember, I think she had about 18 aligners on her first go. And as this loads, I'll just share with you again. Emily was very interested in, she's starting a family with her husband. He was very supportive of her, and wanted her to straighten her teeth. She was upset that her teeth had looked so crooked in her wedding pictures, which is what got her to come in to begin with. And you can see here from the Clincheck, once it opens, that she had 22 aligners. I'm sorry, 22 aligners, top and bottom, on her first go-around. And we'll go ahead and just play through it real quickly. You can see the power ridges where they show up to help torque those roots. And again, both, I said number 8, although number 9 looked like the one that was way out, number 8 was the one that I was torquing the root on. We did perforations along the top here, but in particular I was concentrating on tooth number 8 there. You'll notice also that I have overcorrection aligners in most of these cases. I don't hardly ever use them. I'd say less than 5% of the time. So I kept them on for these Clinchecks so you could see the entire Clincheck and get an idea of what was going on. Here's Emily with just a close-up view right before we're starting treatment. Now we went ahead with Emily, and the first 3 aligners we delivered at 2-week intervals to get the teeth kind of primed and moving. This was early on with Propel. I started Propel at week 6, and then we went to weekly changes with her. And here we are with progress. You can see the attachments in place. This is after we'd done our initial perforation. She ended up getting pregnant. She took a little baby break, 3 months off, and we went ahead and started up the refinement. The refinement was very, very short, and we went 2 weeks with the first 2 aligners in the refinement, and then we cut down to weekly after that. Here's how she finished up. This is just a T-scan. I don't know if you're familiar with TechScan, but I would highly recommend you look at it. This analyzes your bite. It's a little wafer. It shows us exactly how the teeth should hit, and when and where and how hard they hit. So you can see she's closing right now. When that little kite or flag appears, that shows us that we have enough force to actually properly be recording. We're going through the movements here, and I'll stop for just a second. What I really want to do is, if you get it in this gray area, in essence, you're throwing a dart and you're doing all right. If you get it in the white area, that's where you want to be. And in a perfect game, which is what we always aim for, we want a bullseye right in the middle of that little cross there. So you can see that my bite is off to the right side in this case. And I'm going to do an equilibration. I'm going to do an adjustment to go ahead and get it all set up for her. So this is just her opening up again at the end there. So we're now 9 weeks later, we're all done. We're going to do that little equilibration that we talked about. This is her centric relation bite here, and here's a T-scan just to show you how we ended up. You can see that tooth-wise she looks very nice. And here's her bite as we go through it. You'll notice again where you'll see the flag hit. Generally, it's going to hit on a first contact point. Once the flag appears, you know that you've got something significant as far as bite force is concerned. So here we go. Here's the bite force. It's off a little bit on the left. It immediately comes over. This all happens in milliseconds for us, and that's a really nice finish. We end up with her bite right in the middle there. It's fairly even. She's just about 50-50, which is, again, what we're looking for. This is Lisa. Lisa was going to be moving out west with her boyfriend, and I'll skip her Clincheck just for the sake of time, but you can see that the tooth that we really want to release is going to be the lower canine in particular. She's got the crowding down on the bottom. We're going to be doing some arch expansion here to be able to get her bite in just the right place for her. Here she is at the end after 4 months with the little Propel, and this is her refinement now. I'm going to tweak things in. I want to get her bite just right. I'll show the refinement Clincheck real quick. And again, it takes just a minute to open. Sorry about that. I've got a lot of things open on the computer right now, so it slows down my Invisalign Clinchecks here. You notice that I have the new Invisalign Clincheck software. If you haven't downloaded this, I'd highly recommend it. Not only do the teeth look much more lifelike, but it's got a number of great features, including the tools over here on the side. I'll click on tools for a second, and I'll just turn off my overcorrection aligners because I, again, didn't use them, but just to be able to show you what's going on. Now, you look and you say, wow, that's pretty nice, Bri, especially from where you were. But I can tweak that in and get the bite better if I go ahead and do a little more expansion in the back and help to line things up a little bit better in the front. 8 aligners at less than a week apiece for her, and we were able to go ahead and take her to this finish. I'll skip the T-scan again, but you can see we end up with a nice, beautiful result. Actually, I will show you this T-scan. I'll skip them in the future. This is a different. The reason I want to show it, this is a different view. It's the same T-scan, but you can look at it actually and see that we've got a pretty darn nice bite here. This is really even. If I were to equilibrate or adjust anywhere, it would be right up front there. That's a little bit of a premature contact in the anterior region. That's when you see a little bit of fragmentus, and we go ahead and adjust that a teeny, teeny bit. Sometimes I'll see that, and it'll indicate to me that I need to just get a few more aligners to get those teeth positioned better, in which case, if I do that, getting a couple extra aligners is great. It means I don't have to equilibrate at all sometimes. Lastly, we're going to take a quick peek at Jess. This is Jessica. Now, in this case, I'm going to actually adjust her bite a teeny bit ahead of time. I did less than a millimeter of adjustment to be able to take her from this relatively open bite on the sides here with a cross bite into something that was down and a little bit more stable for my treatment. You can again see just that difference there. But getting her more closed, I'm now able to go ahead and proceed through treatment a lot more conservatively and with much more success and confidence, knowing I'll be able to get the teeth moved in the right position. Jess is going to interestingly be a little bit like our previous cases. She's getting married and moving out west, and we go ahead and I've got 11 months complete to get her done. So accelerated ortho was the key to success with this. So we went ahead and straightened her out, got her bite straightened after refinement, and then we went ahead and replaced the old composite up front there, which was darkened, and took it off and placed a nice composite on. You can see there's a little bit of a proportion issue, but that would take a little bit of a gingivectomy to help get, and she was happy with the way it turned out. Jess is just a doll. She's a wonderful person, and this is really, really warm, friendly person who didn't have a great smile. We were able to really improve her smile, take her from something that she wasn't really happy and comfortable with to something that she was much more happy with. Let's now look at, these are cases that I actually started when I did my first lecture. I said, I'm going to start these cases. I started them literally on the same day as the lecture so that I could show you progress as we went through. Sharon's 60-year-old female, very interesting. She's wanted her teeth straightened. She had a snaggle tooth. I treated actually her brother. And she said that she traveled down to Florida, back and forth to Florida. She's got a couple of Merriam bridges, so I'm not going to be able to do any posterior movements around those bridges. But I want to speed up treatment because she travels a lot. It turns out she has a house in Florida, she has a house in D.C., she has a house in Canada, and she has a house in Switzerland. So she wasn't around a lot, and that meant when she was, I had to take advantage of things. Here's Sharon. Her Clincheck, we'll show that one real quickly. Just that general crowding on the bottom, you can see that she's got those Maryland bridges down there, mixed bridges actually. And we're going to be limited as far as our movement is concerned around those. Her Clincheck, I want to say it was 18 aligners, I'm sorry. Don't know offhand. We'll know as soon as this opens up. Uh, 15 aligners, and the 3 of those were over correction. Again, I didn't use those. We can turn those guys off. Oh, that's not what we wanted. Oh, there's just my initial and my final with one of the nice new software changes. But here we go, tools, turn off overcorrection. Now we can go ahead and play through this. We'll make it a little bit bigger for you. And I'm going to leave some space distal here when we're all done, we'll end up closing up. You can see I moved my IPR all to one position. I actually loaded it in the back. The reason I did that is I was going to be go ahead and reducing porcelain on those bridges that I wasn't going to be moving. So Sharon was 12 aligners on the top, 12 on the bottom. We again did 2-week delivery just to honor Burstone's phases there. So we did 2-week delivery for the first 3. Then we did Propel, and we delivered our next batch of aligners of 4 to 8, and then we did 9 to 12, all of those at 1 week each. She took a break. She disappeared to one of her houses, and then came back, and we did refinement. And we went ahead and just equilibrated her and got her into retention, and she ended up really nice. So here was Sharon. We were able to get her bite nice, get her teeth nice and straight. You can see we ended up with a nice result. But we had that one little tooth there that we wanted to tweak in, and we got a couple extra aligners to do it. And typically when I do that, I also am going to zero in the bite and do some other things, and we're going to go ahead and do just that. So we're really happy with how Sharon's case turned out. Another one that I started at the same time as that last lecture was Sharon. Was Mary. Here's Sharon. Sharon was a total of just over 4 months treatment. Mary was the other case I started, and literally when I opened up the previous lecture to look at the cases, I'd forgotten that I treated Mary, because she finished so quickly with such great success that she was off my radar until Monday, when she came in with a bunch of cookies for the holidays, which was wonderful. So we're going to do this without any IPR and just expansion. Here's Mary. She's got kind of a narrow, almost that classical omega arch, top and bottom. We're going to go ahead and, with Mary, do a lot of expansion here, and I'm going to use that Propel just to get some release in the anterior in particular, to be able to move things along. This is Mary's Clincheck. It's like watching paint dry. Sorry about the time it takes there. We'll go ahead and move that over. And I've got 19 aligners for her. Again, overcorrection, which I use often, or ask for often, but rarely use. And we're going to go ahead and do that osteo-perforation on the top and the bottom, only in the anterior. I'm going to get good expansion in the posterior, so I didn't have to really worry about that. You can again see the power ridges, which are automatically placed, so I can get some good root torque. One of the things I want to share with you is how accurate not only the Propel technique is, but the Invisalign Clincheck. Look at how this tissue ends up right here in the lower anterior. Just to give you an idea how realistic things are, that was how it looked on the Clincheck. And then Mary's treatment sequence was 15 on the top, 19 on the bottom. I had 4 passive aligners up there. Again, we went 6 weeks with the first, just to prime the pump, get that initial movement. We went 1 week through treatment, and then I took the attachments off when it was time to go ahead and go to passive aligners up there, so I didn't need the upper attachments anymore. I did a little bit of isolated Propel on the bottom at this point, just to wrap this thing up, and then I had just not even a month of refinement. I listed it as 1 week each. I think we went 4 days. We went 1 week for the first one, 4 days for the others. A little bit of enamelplasty, some minor bonding, and some equilibration to show you that these cases are real Propel cases. Here's Mary, and you'll be able to look and see just by looking at her teeth, especially the chipped one that you'll see in just a little bit here, that one, that this is actually her. Here's the perforations. One of the reasons I wanted to show this is what you see the next one here. This is sloughing that occurs from leaving that topical on too long. That's a profound topical there, and that tissue sloughed off. It was totally my fault. We had the timer set at 10 minutes, and I left the profound gel on for 10 minutes instead of just 4 minutes. She was fine. You'll see that this mucosal layer will place itself in 2 days, and she'll be back to normal. But I wanted to get an idea of what happens if you leave that topical on too long. So here's Mary with the attachments on and in the middle of treatment. Now we're going to go ahead and at the end we're going to do a little teeny Propel of taking off the attachments on top. I always want to, like a Boy Scout, I want to leave my campsite cleaner than I found it. So I'll use a ET 13 fluted burr, composite burr, to go ahead and remove the bulk of the attachment. Then I always use a porcelain polishing set to get the rest of it off. I always share that with the patient. I say I have 4 steps. First one, get the bulk of the attachment off. The second one takes the rest of the plastic off. This is the Axis Ceraglaze system. You can use the Brasseler Dialite system as well. The first one's a coarse one. The second one, I say, puts the shine back on. The last one puts the glaze back on. That tooth is nice and healthy again. The enamel's burnished and strong, and it'll still bleach if you want to do that, but it's in good shape again. Here's Mary again at the start, and here she is at the finish. Teeth nice and straight, and Mary in good shape. I have George's case in here, backing up here. So Mary was just about 5 months total treatment, not even 4 weeks for the end. George is a complicated case, and I decided I'm going to move this to our third seminar that we're going to give. And the biggest reason I want to do that is I want to show a lot of different steps that we use to help accomplish George's goal, and it's going to take more time to go over and show all this. But it's a great crossbite case. He's got a narrow arch. It's almost a Brody type bite, and it's a real interesting case. We'll be able to look at it and see how we can work with that in the next seminar. Now let's talk briefly about cyclical forces or vibration. There's a lot of different things out there, but Propel came along with one that they call the HFV, the high frequency vibration system. It's an FDA-approved device, or exempt medical device, class 1. You wear it for 5 minutes a day. The vibration helps to seat the aligners, and we think it may help with movement as well. So I've got a number of reasons why I really like using these things, and we've had good success with the vibration technique. It really comes in a nice little box. It's about the size of a baseball, the box itself. It's got the oscillator and the mouthpiece. They snap together, and then there's a USB flash drive and a power charger for it. And this is just the steps that you use. It's safe and easy to use. I can share with you right here, probably the most important thing is just this 5-minute use. Shuts off automatically. I've got my patients really trained to just use this in their car, literally. A lot of them will use the USB charger with a little 12-volt battery thing for the car. I'm like, listen, if you're in your car, pop this in your mouth and just hope you don't see a neighbor. But you'll be able to go ahead and get those teeth moving and working more quickly for you. There's a little light system on it. Blue basically means that it's working, that the cycle's in process. Basically, if it's red, then that means that it's been stopped. And if it's magenta, it's low battery. When it's that amber color, it's charging. We'll assign the nice thing about it is there's a little software, a little app that's associated with it, and you can use this to track patients' compliance. But also patients can use it too if they want, which is really, I think, a great little helper for them. Now, let's look at just briefly some combination cases. This is where I use both high-frequency vibration and micro or manual osteo-perforation to go ahead and accomplish our goal. They're the classic cases, this lower crowding, and these are going to be 4-month treatment start to finish. So Kate, I literally started after the first lecture I did, and finished it before this lecture. So it's just a great example. Here she's got that lower crowding. We'll go ahead and circle it in red for you. You can see the area in particular where we want to focus on. She's got some crowding up top because I always like to share with my patients your teeth fit like a lid over a jar. We have to do both arches to get things to coordinate. So we're also going to pay attention to something else here. I want you to take a peek at her occlusion. All right, I'll show you actually, let me back up for a sec. Before I show you the occlusion, I'll show you the spots where I went ahead and did perforations. Lower, I just did 5 of them in these areas. There we are, and now those arrows show the occlusion. I want you to see how nice and tight her class 1 occlusion is in this situation. And I want to share with you something that happens oftentimes with clear aligner therapy. We end up with the bite not settled in the back. It's not completely finished. And a lot of docs will just say, oh, I'll let that settle. I personally feel that that's not, I think I consider it sloppy. So I always look to finish my bites as best as possible. And with Kate, we're going to go ahead and do a teeny bit of refinement to get that socked in, and we'll do a little equilibration when we're done. We're looking at that bite where it's a little bit open there. You can see that it's not completely settled, and here it is settled when we're all done. So we ended up with a really nice result. 4-month treatment. Kate was in and out and loved it, and has sent in a couple of friends, which is one of the wonderful things about being able to do both micro osteo-perforation and HFV technique. Nice tight bite there. We'll take a look at Brett. Brett's a great guy, just wonderful friend of my partner. Same thing, he's got that lower anterior crowding, and we want to really make sure we get things zeroed in. His bite is also nice and tight, but notice he have fractions on his canines there because he's got that kind of deep canine area, bite when he goes into his excursive movements. Getting that bite more settled is going to help him in the end. So looking at, again, just the occlusion, I'll pay attention to that. Here we are with the crowding on the top there. You can see those areas of abfraction that have occurred. Hygiene could be a little bit better. Here we are looking at Brett in the middle of treatment after having done some MOP. He's using his high-frequency vibration system, and the bite's still not settled back there. We have too much anterior contact, too much anterior coupling, and there's fremitus. So in order to get that bite settled, we're going to go ahead and do some refinement. We get a little bit better, and the bite's still not closed all the way. The last aligners help to bring him back in a nice solid position. Look at the canines. I've got those guys up. We still have perfect canine guidance in his case. Used the T-scan to zero him in, make sure everything was all set. Ended up with a great result. Nice tight bite in the end there. This is on some of the patient materials. They've got some great things for the high-frequency vibrator called the V-Pro 5, and a really great instruction guide on how to use it for patients. So I've got just some questions here at the end to go through with you, and we'll just kind of walk through how do I introduce the manual osteo-perforation to my patients. I really share with them that it's minimally invasive, and that in essence it's a little dimpling procedure. And the big trade-off is that you could decrease the time significantly and really improve your clinical results for the mild amount of discomfort that might be associated with it. What if I happen to get too close to a periodontal ligament space? Well, first time this occurred to me, the patient let me know right away that I was in the periodontal ligament space. They felt it. And she said, hey, you know, this one hurts, and I actually kind of kept twisting and backed out, and that was the one area that was sore for her. Took about 3 days to get back to normal, but it healed up fine and didn't really cause any trouble. We know, more importantly, that there's not a lot of literature, but there's literature that shows that this has occurred routinely with TAD placement, and if you really kind of get out of there and you've used a nice sterile technique, it's going to heal, and there isn't going to be anything else you have to worry about. The floss technique down here just means if you take a piece of floss and hold it straight right at the interproximal between the teeth, it gives you a great idea of where you want to place your micro-osteo-perforations. Well, how do you manage patient discomfort? And we talked about how you cannot use non-steroidal. I think that's the most important thing. But the acetaminophen oxycodone or a hydrocodone with the acetaminophen I think is great just for 3 or 4 days. I've had some other patients and friends say, you know, it works just as well, Bri, as a little bit of that single malt scotch that I've been saving, which they can use just well with Tylenol. So that's fine by me also. What about post-op infection? I haven't seen any. I've never had post-op infection associated with it. I think it's minimally invasive. If you just follow the protocol of using some chlorhexidine, wiping down the tissue, I don't see it, and I don't think antibiotics are indicated. What about the change interval? Well, you know, we're going, instead of every 2 weeks, from every 2 weeks to every 3 to 7 days, with a reintroduction of the micro-osteo-perforation at every, say, 10 to 12 weeks, even up to 16 weeks at times. Are there any contraindications? This is, again, my own list that I put together a number of years ago, and basically it's going to be patients with bleeding or immune disorders. Ones who are very anxious are not going to be a good patient for this. Ones who might require prophylactic antibiotics or had a history of bisphosphonate use. I'm not as worried about the bisphosphonate thing as much anymore. We've got a much better handle on it, and those that have been keeping up understand that it's usually associated with intravenous use and long-term intravenous use at that, generally associated with post-cancer treatment. No anti-inflammatory, so if someone's taking it for arthritis, they won't be a good candidate. And then as just a precaution, I also put down any previous radiotherapy to the jaw would probably eliminate the use of MOP. Now, what it doesn't do is it doesn't keep me from using high-frequency vibration, and the vPro 5 is great for that. I introduced that to patients, that it helps with the aligner seating, and that it also increases compliance. And then the biggest thing I discussed with them is how easy it is to use. But probably the best thing I can do is just show them cases where we've used it and how it's speeded up treatment, and that usually gets them right on board with any high-frequency vibration that you might want to incorporate associated with the micro-osteo-perforation. vPro 5 is great for that, and one of the reasons is that they don't actually even talk with this to the doctors, but I think it's important to know that they've got a guarantee that no questions asked, they'll replace it in 60 days. This is really just for you, the doctors. I don't think we need to share that with patients at all, but it gives you a little bit of satisfaction knowing that if you got something that doesn't work, don't feel like it's the right thing for the patient. In the first couple of months, you can send it back for replacement, full refund. And then the unit itself has a 1-year warranty. Now, that brings up an interesting thing, because one of the competitors has something that I call the suicide pill. It's a built-in thing that makes the device die after a certain amount of time. In essence, I guess it's to keep you from wanting to have you share it with another patient, which might all be well and good, but we had in the past some of these appliances not last as long as we wish they would. And there's no suicide pill associated with these. They last for a long, long time. Well, that brings up kind of the most recent thing, which is Invisalign. Align Technologies came up recently with what's called a 7-day wear protocol. And I want to share with you, as a faculty member, one of the interesting things. There's really no change in the materials themselves or in the software associated with that direct 7-day wear. What they noticed was that with the aligners, that they kind of had a built-in 12 days of active movement with them, and the last 2 days were kind of passive. So they noticed that some of the faculty and consultants had sped that up to a 1-week change. And you could get away with that for a certain number of times. I actually have a slide that shows how this overlap occurs, but after you get a number of aligners ahead, you actually are getting to the point where you're in the very early stages of movement, and it tends not to work. The other thing that I've noticed that we haven't been good with messaging about so far is that you still aren't honoring Burstone's phases. So in the initial phases of clear aligner therapy, changing them weekly, I still go 2 weeks for the first aligner to really, again, prime the pump. You have to get that hyalinization phase going in order to get true good movement. Then the kind of nice thing is, if I'm doing that and I use the MOP and HFV techniques, it keeps my 7-day on track, but more importantly, I then can decrease even quicker. Now, if I do that, it's very, very important that we number and label the bags properly with the change dates so that the patient's aware of when they want to change them. And more importantly, as the quarterback of this team, doctor, you must monitor this case very carefully, because if it starts to go off track, you're not going to be able to go backwards and find an aligner that it fits into. It just won't fit properly. Just some factors that affect this ability to change the aligners quickly would be compliance, obviously. But some of the other things are the difficulty of movements. And this is the tooth movement assessment that I'm showing green, blue, black. You should be aware of that when you're doing Invisalign. One of the nice features that they have is they're able to predict the relative success with different types of movements associated with it. Also, you want to make sure you have enough force and space. If you haven't created enough force or haven't done the right amount of IPR, it's going to affect the ability for the teeth to move the way they want to. As will poor attachment placement. That ties right in directly with force, because if you don't have an attachment that's placed properly, there's a lot of flash, that I typically call it a fried egg, then it's very difficult for us to be able to have it grab properly and move. The density of bone will affect it, as will ankylosis. And finally, I have to swing back around to the very first thing. I think the biggest factor affecting aligner change is compliance. And this is where our 2 devices that we talked about today can really make a difference. So how do I charge for it? Well, there's a lot of different things you can do. You can build it into the fee. You could charge for the device itself, for either your MOP device or for your B-Pro 5, or you could charge a fee for a reduced time option. But I found that I like to just combine the treatments nowadays, use both of them together, speed up my treatment, and this is what I do. I just build it into my fee. I say, you know what? We're able to do really beautiful, high-quality movement of your teeth in an accelerated fashion that other practices can't do. And you can talk to some of my patients or some of your friends who have had it to see the results. With that, I'll be able to take some questions here. And I see that Joe has a question, so give me a second here, Joe, and I'll go ahead and open up this segment and see if we can answer them for you. Joe asked, hang on a second here, sorry. Do most docs charge extra for this, and what is the price range, which is additional? I'm sorry, that's actually from William. William, again, I just build it in. I found that that's the most successful way for me to be able to do it. We just include it in the cost. And the biggest thing that I didn't share with you is if I take my treatment, which is normally, say, 12 months, and cut it down to 4 or 5 months, or even 6 months of treatment, I've cut my time in half. And that's where I think the biggest savings for me is. So I don't mind that trade-off. We discussed how, even with the 7-day aligner change that aligners proposed, that I think that this keeps you from running into trouble and gives you great success. Stephen asked, how important do you feel it is that to use the 2-week phase before Propel? I've been using Propel prior to aligner 1. I think it probably is, again, I'm going more from the science there, Stephen. I just have to share with you that I kind of like to honor Burstone's phases of tooth movement. I can't say, because this is all going to be anecdotal, I can't say that there's any disadvantage to it. I can share with you that I've done a number of anterior lower single tooth extractions on severely crowded cases. And in those cases, we'll take the tooth out and start moving right away. So that kind of fits right in with the model of Propel that you're using it for, which is to go ahead and start in right with a little micro osteo-perforation on the first aligner delivery. With that, I'd like to share with you, though, that one of the reasons I also like to wait a little bit is I want to gauge kind of where the patient's at as far as both compliance is concerned and know that they're over the hump of just the initial wear of aligners. The flip side of that is that I've got a buddy who says, you know what, I'd like to get it all done in that first visit. And that's where, Stephen, you're probably coming from. I think it makes complete sense. Ashley asked, how do you make the bite tight in the end, and what do you ask for in refinement, and do you use special attachments? I don't use special attachments. I use the optimized attachments that are indicated. The best way for me to make the bite tight is, again, to use the T-scan, the tech scan. I just can't tell you, it's one of those things that I can't live without. There are certain things I can't live without these days. I consider them typically just like composite in my toolkit. One is Invisalign, 2 is Propel, the Propel systems, and then 3 is T-scan. Just using those things together to end up with a really nice, beautiful bite is just going to mean success. And in particular, when I say it's going to mean success, what I mean is that the difference between us and an orthodontist as GPs is that we see these patients every 6 months, and if we don't have that bite right, you're going to see it when they come back for their recare visit that it isn't in the right position, and then it will settle. And when it settles, it doesn't settle where you want it to. So look at doing that. I'd say if you're interested in understanding a little bit more about how those bites work, the Pankey Institute and the Dawson Institute are the best places to go. Joseph asked, what type of retention am I using? I got to share with you, I use all different types of retention. I love the Vivera system from Invisalign. I'm probably one of their biggest cheerleaders. But I also share with all the people at Invisalign that the standard of care of removable orthodontics for retention is going to be a Hawley appliance. A Hawley will last longer. It's not the wire on the outside. It's the scalloping of the acrylic on the inside that holds the teeth in place. It does a beautiful job. But you can't bleach with it, and it looks like you're back in high school. So generally patients say, you know, I'd rather have the Vivera, and I'll go ahead and replace those on an annual basis. You get 4 of them, so you get at least 4 years worth, which is typically what we figure. We say they average about a year. They last about a year, and we really like them. You noticed in a couple of cases that I did some canine uncoupling. Do I place composite to fix that? I did actually place some composite in a couple of those. That's my good buddy Joe who's asking those questions. Joe, good to see you online here. How much the devices cost? I'm gonna defer just that to your area representative, because they've got deals for the amount that you buy at you know, if you buy them in bulk, it's going to be cheaper. So William asked, so patients are coming in for every 6 aligners instead of every 3, and the answer is yes. Once I use this system, we typically will give them 5 or 6 at a time. They'll come in at a 5 or 6 week interval, so the interval is the same, but the aligners change. They're quicker, and we accomplish the treatment faster. So they're still coming in essence, every 6 weeks, not every 3 weeks, and we use that as just kind of our benchmark to be able to stay on top of things. It really has made things a lot simpler. I think that's pretty much it for questions tonight. I hope you enjoyed the seminar. I look forward to sharing the next version of it with you. I've got some really great complicated cases. I'm looking forward to showing you some cases where we place some implants and set the case up ahead of time by using Propel, and used our vPro 5 to help make sure we have aligners seated well. Thanks for attending, and I look forward to sharing some knowledge with you again in the near future. Have a great evening.